debate style because I've spoken to everyone here and they definitely don't agree what the vision of the new clinic is. So we are definitely, feel free to do that, feel free to disagree. We are going to be up here for an hour talking about care and then another hour talking about the realities of delivering that care and the cost. So if you notice that everything here is somewhat in a circle, we wanted to create kind of an oval. And so we want this to be interactive. So please feel free to raise your hand if you have a question, if you have a statement. So we have about 17% of you are physicians and scientists, 17% are payers and providers. There's a lot of smart people in the audience. And so please feel free to ask questions. And let's give a great big hand for Archana. She's here. And this is my co-host. So I was just preparing them and welcoming them, Archana. But HP is our main sponsor. Archana and I are our co-producers and co-hosts of this event. This is actually our 7th event. And just a little brief background, we put these together because we wanted to just get really smart people together around one topic and just talk about it for 3 hours from multiple perspectives. And I think we have been pretty successful. This one event was sold out, so our events are starting to get popular, and we actually want to keep it intimate too. So if you notice, it's a small crowd, but we want to keep it that way because this way we can all engage.
So. Yeah, and so welcome to HP. And I just wanted to kind of say a second again that this is our 7th sold out event. So we're talking about an important topic, future of clinics. So before we jump start on it, I want to highlight a unique opportunity that we will all have today in the break period for HP to also showcase their healthcare edition, how they are reinventing the clinics. So that's something that I wanted to highlight. And then welcome our panelists.
I do have one last thing. So we do have our next salon is September 12th. So Kristen, if you want to put that up, it's Reinventing the Doctor. There's a lot of overlap with the discussion today, but it's Reinventing the Doctor. It's at UCSF. UCSF Health Hub is also our sponsor and partner. So if you look at, there's a code there. If you only today, if you put in that code, you will get a steep discount. It's like $20 to come to that event. So take that code down, and you have the URL. But please join us to continue this conversation. So with that, I guess we can start this one.
We can jumpstart this one, and I would like to urge each one of the audience, you're here because you have a question. And if you have a question, please engage and share that question with us because we have a great group of speakers right here. Normally, how we start or jumpstart this conversation is to introduce our speakers. And I think nobody else can do a better job than the speakers themselves. Because we want to learn what your journey has been to become the strategist and thinking the future of healthcare delivery as we know it. So we would like to get started with that. Maybe, Bambi, you want to start from your side?
Sure.
Amanda, you can start, and then we can go back and forth.
Hi, my name is Mona Chadha. I'm the Chief Strategy Officer. Can you hear me? I'm the Chief Strategy Officer for Dignity Health. And my journey to healthcare, actually, I really come from the world of genomics and precision medicine. I worked for over 20 years for very cutting-edge enabling technologies that brought in the ability to do kind of the genomic analysis, the precision medicine that we are all looking for, and giving us the opportunity to look at multitudes of data and being able to analyze and figure out how to make sense of that data. So I was very fortunate to be in the very forefront of being with those very cutting-edge enabling technologies and brought them from concept to commercialization, so i.e. the sequencing technology for Human Genome Project and then many other enabling technologies for biomarker discovery and validation. So I come from the molecular side of things and got into the world as big data started becoming more prominent, and we started really looking at genomics, and then we started looking at proteomics, and started looking at how disease really should be managed, and really taking it all the way down to how, how clinicians are making decisions, how researchers are making decisions, then that continues to how how and when will the technology impact like clinical decisions, and what are the clinical researchers doing, then all the way to how physicians are making the decisions, and then into routine clinical practice now. And so through that journey and channel, I was brought into Dignity Health as a chief strategy officer, and you'll say, oh my God, that's a totally different world, and really it is. And the reason I came into that world was I was also part of life science angels, investors, and looked at many different technologies that will, with all the data available, how do you really make these critical decisions, and then how do you put them into practice, and then what does it mean for the future of clinics and the future of doctors. So I felt that there was this gap from coming from the technology end of things, being able to bridge that gap, and something in my personal life just drove me towards Dignity Health. I got care in one of the hospitals, and we started talking to the physician, and just felt that there was a real gap that we needed to bridge, and we need to bring in more entrepreneurial energy into the hospitals. An opportunity opened up, and my boss was very, forward thinking. He said, I really want to bring someone in from outside the traditional healthcare world and start bringing that energy and technology focus into our thinking and into our hospitals and into our clinics, and really start paving personalized medicine vision of what personalized clinics would be and how care in the future would be delivered, and hence my journey into Dignity Health, where I've been for a year.
Excellent, thank you.
Want to go back and forth? Oh, go ahead.
Sure. Hi everyone, I'm Justin Zaghi. I am the medical director of Heal. And for those of you who don't know about Heal yet, Heal is a simple app, or online you can book, but basically we send a doctor to your house within 2 hours in some cases. We really started as like an urgent care business, and we're morphing into a primary care business because patients love the experience, and we want to promote continuity of care as much as possible. And the way the business started was the co-founders are actually a married couple, Renee Dua, who's the chief medical officer, and Nick Desai, who is the CEO. And so Renee, she's actually a nephrologist, and Nick has built several companies before successfully. And so, the story they share is they had a child who was sick, and they had to take the child to the emergency room and had to wait over 8 hours before they were seen. And, understandably, they were very frustrated, and on their way home, they said, why do we need to wait in the emergency room this long? Why can't we have the doctor come to us? And so, I think we're increasingly seeing a trend of care leaving the hospital and entering the home, and this is where we are like solely focused. And so, basically what happens is we send a doctor, typically like a licensed board certified doctor, with a certified medical assistant, comes to the home, delivers convenient care, has a medical kit that has basically everything that you can see in a typical doctor's office, and are able to provide really comprehensive care. And we are a tech company as well, so we couple that with telemedicine, including video encounters, as well as the ability to check patients' vital signs at home, whether blood pressure, their pulse ox, we can check their blood sugars at home. And so this enables us to maximize our reach and our scope of impact in the patient's home.
Oh, I've always wondered about Heal. Thank you. I'm Jenni Vargas, and
Oh my God.
I know. We've talked on the phone, we've never met in person. I have had a very long 40-year career in healthcare. I've been all over the place. I spent 20 years on the payer side, which is great education, not good for cocktail party conversation. I was not a popular person when I was doing that, trying to manage care back in the 80s. It didn't work very well. And I left the payer side, and I went to Stanford Healthcare about 12 years ago, where I was for about 10 years. And interestingly, at least interesting to me, early in my Stanford career, I met the founder of One Medical, Tom Lee. And I went to their first clinic at One Embarcadero Center. And let me just ask, how many are One Medical members here? So quite a few. So a lot of you, thank you very much, first of all, really appreciate that. So a lot of you will know what I'm talking about, but others, we can figure out how to make you a member. We went and visited the One Medical Clinic at One Embarcadero Center because they were doing something so innovative, so cool, and Stanford needed to expand into primary care. We really weren't doing primary care, as many academic medical centers don't. Spend a lot of time and energy on primary care. So we actually decided to loan One Medical money to put up the Palo Alto, Sunnyvale, and Burlingame clinics, which are fantastic. And so it was the beginning of our journey into primary care. So my life, I left Stanford, and the CEO of Stanford, Amir Rubin, also had been exposed to One Medical, and he was recruited to become the CEO at One Medical. So he's been there a couple of years, and then a year ago he recruited me to be the Chief Strategy Officer. So I'm just so delighted that this long, winding 40 years has gotten me to such an innovative and exciting place. And I'm really excited to tell you more about it as we go through the panel. Thank you.
I'm Pat Carroll. I'm 3 days into my job at HIMSS, so don't ask me too many questions on it. Prior to starting at HIMSS, I was Chief Medical Officer at Walgreens for 5 years, so responsible for all the healthcare strategy, developing the retail clinics. Really anything to help around healthcare I led, and so it's interesting. I've been, first day of work was Monday, and before I came here, I worked right to the last day at Walgreens, and I met with the CEO, Stefano Vicini. He's a really interesting guy, 78 years old, from Monaco. I think he owns 20% of the stock. And he said, "Patrick, why are you doing this? Why are you leaving Walgreens?" And it's an exciting opportunity.
What did you say?
Good question.
You know,
Exciting
what I said
opportunity.
is, I said I want to be part of a smaller team doing something that's building very quickly and offers opportunity to be on the ground floor. I think he understood that. So 350,000 employees to 60, okay.
Now, what was your real reason? No, I'm kidding. No, I'm kidding.
So glad to be here. I do know a fair amount about HIMSS because I did take the job. And I know a lot about kind of retail health and what the pharmacy players like Walgreens and CVS are doing in healthcare, which is, in a way, there is a thread of connection between what Walgreens is doing and what HIMSS and HERS is doing here. Really consumer-facing, price-transparent care. So we can talk more about that later.
I'm Karoline Hilu. I have been on the ground floor. I am the Chief Strategy Officer of Crossover Health. I've been there for just over 4 years, and that title really entails everything. The folks in the audience here from Crossover can kind of laugh, but it has really been every job. I have loved it. But less about the kind of career path. The reason that I am at Crossover and what has led me to strategy, and I love the fact this is kind of the strategy symposium. I grew up on the Polish-German border. When Poland was still a communist country, I came to the US as a teenager, and my only real passion is systems and game theory. And I have 2 beliefs. Number 1, inefficient, unfair systems must fall, and that is how I feel about the US healthcare system. And number 2, I have always been perplexed, maybe troubled, maybe depressed, by the fact that I can get much better care in Poland, which resembles a second or third world country, than I can here, on average, with the exception of some great institutions mentioned here. And so at Crossover, our ambition is one of irreverence and disruption, and really fundamentally changing the system, and it has been a wild, wild ride getting there.
That's a hard one to follow. All right, hi, my name is Yumi Taylor. I am founder of TeraPractice, which is a primary care virtual first, value-based primary care startup within Sutter. We've started with Palo Alto Medical Foundation as our initial home, and where we launched about 15 months ago. It's been amazing to have kind of the infrastructure and resources of an integrated care delivery system that has retail clinics, that has specialty access, hospital systems, has a payer. For me, my journey, I started out, I'm a primary care physician, internal medicine, practiced in Western Pennsylvania for 6 years, and was doing traditional practice, and eventually, and just very much recognizing that the fee-for-service world is just, it's very, it's a broken system for both providers and payers. And so was fortunate at the time, Highmark, which is a very innovative payer, was partnered with our community practice. And so I had the role of being the champion to roll out a new payment model, and basically value-based payment model for 8 rural clinics. And so that was my foray into value-based care, and something I've really sort of believed in for quite some time. And also now recognize the importance to have that as an underpinning to really do innovation and disruption within care delivery. And so my background is in informatics, so I have fellowship trained in informatics, so I have a system and perspective about data, about IS operations at healthcare system level. So it's been great to sort of walk into this role where I was able to build something from scratch and not have to work with sort of change management and all of that comes when you're doing something at a systems level. So I have this great team. Chris Waugh is with us. He comes from One Medical, but his team, his design and innovation team support our practice. There's some here today, and then just have operational support of some just within Sutter and PAMF. So they're here, but happy to talk more about our lens and how we see the future of primary care delivery for Sutter moving forward.
And you trained at HP.
Oh, yes, and I'm coming home, of course. Yes, I know, I said that when I first came. Yes, so HP has been an incredible, in supporting, they supported, I did my fellowship training at Stanford, and so HP funded the fellowship when I was there. So it's great to come back home, because I spent some time here working, with HP, spending some time, so interning. So great, thanks.
Hi, everyone. I'm Heather Fernandez. I come here through a quite nonlinear path. Started my career in politics and policy. Spent a lot of time in consumer tech, and if you would have asked me even 4 years ago that you would be on a panel with so many incredible folks from the healthcare industry, I would have probably thought you were mad. Most recently, I spent basically a decade starting at the early team at a company called Trulia in the real estate space. There were a bunch of us in the room, one homeowner, because we were in our 20s in San Francisco. And so, of course, none of us owned homes. And we had a thesis, which was, how do we bring power to the people? Right, and how do we use data to connect consumers with information and connect them with a supply side that could increase service levels for that consumer, right? And many people may know the Trulia or the Zillow app, but that was sort of at its core what we built. We did that over a decade. What a lot of people don't know is 60% of that team at any one time was working on the supply side of that marketplace, building SaaS tools and ways to help improve the performance of the real estate agents and brokers to help connect them with consumers. Power to the people. In that time, I had 3 kids. I spent a lot of time in urgent care. I thought I was alone. I thought that, I'm just a crappy mom who can't make it to the pediatrician who's only available Thursday at 1:30. And we had this insight, which was actually, there's a consumer-driven shift happening in healthcare today. And I'm not just a crappy mom. This is actually a consumer-driven trend around convenience and access. And a lot of people have talked about, at least coming from the Valley, a lot of people talk about telemed, which of course is an incredibly important part. But you had 10,000 clinics across the United States serving 150 to 170 million patients per year. It effectively became the front door of care. I brought that thesis to healthcare industry folks, and they laughed me out of the room. But then I did the work, and I thought, actually, there's a thing here. And informed by so much of what I saw from a lot of the folks up here, as well as what we'd done at Trulia, we thought, let's build a company that enables that. And so I'm the founder of something called Solv. We build software on the provider side, much like Trulia, to enable a superior patient experience for the consumer. And then on the consumer side, we try and answer a couple of questions. Where should I go for the problem I have? When can I be seen? And how much does it cost? We've been around for 3 years. We've seen roughly 6 million patients through the platform to date. And sort of self-reported from consumers, we've helped divert from the ER roughly, we estimate 150 million in healthcare savings. And so I'm really excited to be here with all of you.
Okay.
Thank you. So I would like you to keep the
Oh,
mic
great.
for the speakers because we are mic'd up.
Great.
Okay. So
I'm going to start, well, Heather brought up a great point. So we're going to, trust me, we're going to cover a lot of topics from what is care, what is the new clinic. But what I want to start off with, and Heather touched on it, was that there's been a consumer-driven shift in care. And so from a high level, and I want to bring in Jenni because she talked about her 40 years in this industry. So she's seen a lot in healthcare. And so, well, you said it like 3 times, 40 years. So what happened from a high level, what's happened in the last 10 years or so? Because One Medical is probably, what, 2007 started? Crossover 2010?
12 years old.
Yeah, 12 years old. Yeah, so in the last, decade,
Yeah.
what happened and why are we seeing a change in clinics? And it could be the consumer driving it, technology, economics. What's your view?
Well, I think from my perspective, you're not a terrible parent.
I think so too.
Right?
I think I'm
I think what's happened is the world has gotten much busier, and the idea that you would make an appointment 6 weeks from now and go to the doctor's office and wait 45 minutes in the office for 5 minutes with the doctor just does not fly in 2019. So, I mean, when you can have your food delivered, in an app, and you can get your car, and people are just not willing to put up with that. So, I think, honestly, I can blame the managed care companies for sort of taking us down the wrong path, as if, by having all sorts of Mother May I rules and regulations, that was going to fix healthcare in the United States. Obviously, that did not work, still not working. But actually letting consumers, use the services they want, whether they're at home or they're on an app, is the right way to go. And the other thing that I'll just have to say about my time at One Medical and my observations of having spent my entire career in this business, is that One Medical, founded by Tom Lee, a very visionary physician, Archana knows very well, he really said, I want my doctors to be customer service oriented. So we hire and train and monitor the performance of our doctors very much on a customer service basis. If you're a One Medical patient, when you arrive in the clinic, there is not a medical assistant or a nurse that's going to room you. The person at the front desk very nicely says hello, and they push their computer, and the doctor has 2 minutes, that's our SLA, to collect you from the waiting room and take you back and spend a full half an hour with you. Now, when Tom started this, a lot of physicians said, and we can get physician feedback, what? I worked at PAMP back in the 80s, and one of the things I tried to work on was wait times back then, and I couldn't get anybody paying attention to me. I was like, guys, everyone's waiting, and they're like, what? Because there is, and I've noticed this in my time at Stanford as well. Stanford, amazing institution, amazing doctors. The doctors are doing research, teaching, and clinical. And so they've got like 30 seconds to cram all their clinical in. And so they've got rooms lined up. Patients are in rooms, and they go room to room to room to room, right? Well, which makes for a crummy patient experience, but a great doctor experience. So what I think we're seeing now is lots of companies who are saying, actually, it's the consumer that matters. And we're going to do what they want. We're going to spend the time with them. We're not going to make them wait. We're going to be respectful. We're going to answer their questions. And we see this a lot with One Medical patients. If their issues are behavioral health and not exactly primary care, we're going to help them with that. We're going to help them integrate into the rest of the ecosystem if that's what they need. So I think it's just a tremendous shift, sort of both the providers and the patients. The insurance companies, from my mind, have not caught up at all. I mean, they have a long way to go. I mean, they're offering Teladoc and American Well, but not integrated into anything else. And so people are like, I'm not going to talk to the person that, I've never met before, doesn't have my record. right, in the middle of the night. So we're making a little progress, but not as much as we should.
So as a follow-up question
Yes.
to that is, it's almost like the phone and instantaneousness has arrived to
Yes.
healthcare.
Yeah.
And it's almost healthcare is catching up to other industries.
Yes.
But it's also like in the perspective of One Medical or in your career in general, you are redefining care, how you measure it, and what it truly means to
Yes.
the end user, which is your member and the provider. Is that something that you're
Yes.
kind of driving to?
Yes, and to that end, we look at Net Promoter Scores every day.
Mhm.
That's not typical amongst traditional healthcare providers. We also look at our HEDIS scores. I mean, we collect all the data. So I think it is changing. We still have a long way to go in the industry, but we are very, very focused on the patient. And that's really, you don't work there if you don't want to be focused on the patient. And that's just very different, as opposed to, you have other obligations or things you need to do, or, people you need to respond to. And one other thing before I turn it over is, our doctors are all salaried. They're not in any way incented to rush you, see more patients. We also make it very nice for them, so that we don't want them to be stressed out, and we want them to be relaxed. So we give them the time. They're supposed to take a 30-minute appointment if that's what you want, and they'll talk to you about whatever you want to talk about. So that's a different model, unfortunately, in the fee-for-service world. In many instances, providers have to be on a treadmill, if you will, in order to generate the income to cover the costs of the thing that they have.
So also full disclosure, right?
Yes.
HP does have an on-site that is run by Crossover, and HP does have several employees who do see One Medical and
Yes.
Dignity and several and
Yes.
Sutter too.
Sure.
So as we're laying this conversation, I want to have that conversation around integrated solution and the very member-centric solutions that we are seeing that takes us in the future of clinics, which Karoline wants to fight.
Thank you. No, and I appreciate the disclosure. So I would agree with everything that Jenni said about the consumer. That is at the core of the crossover model. One layer that crossover does differently is we believe in the trend, to Bambi's question, of this health activist employer who has given up completely on managed care, given up on the government as an entity to change healthcare, and basically taken it on themselves. So crossover sees itself as the partner for these health activist employers, many of whom are big employers here in the Valley. And the core to our value proposition is, because we are not fee-for-service, meaning not at the behest of those perverse incentives, we take out approximately 30 to 40% out of the total trend on a risk-adjusted basis at maturity, meaning our model, this tech-enabled, data-enabled model, basically can prove that for the most part, the fee-for-service system is hugely inefficient, right? If you can achieve that kind of bending of the cost curve on such a short horizon, which is what has been so exciting for us to say, we want everyone to get on that bandwagon, because those dollars could be reallocated to much more valuable things. And that's why what you're doing is so cool.
Yeah, no, I mean, I think just to add to that, I think that, there's a lot more potential for innovation when you don't have to worry about bill submission and paying for episodic care. And then there's a lot more potential, I think, for really doing that care coordination and helping to manage what I call, sort of affordability of care. So even, I think in certain ecosystems, you may be able to have individuals, employers, patients who can pay additionally for care. And I think a little bit of our lens is to be able to provide very efficient, a satisfactory sort of patient experience, at an affordable price point that really is accessible for all and not just for certain pockets. Yes, so I think it is exciting to sort of to work out the pace. I see one of the challenges, I think, is you do have to have close alignment with a payer, because you do. I think ultimately, when I think about pipeline and scale and growth, and again in certain markets, managed, there are PPO, there's a predominance of PPO. So it's just figuring out a new model to be able to manage even PPO patients in a value-based way. So that's a little bit of what we, have started thinking about, but just.
So I think
probably
what
needs to be
we're
solved.
hearing a little bit is the model's outdated. Obviously, we're going to talk a lot about the cost and value-based care in the second panel. We heard, and this is the first time really, the health activists, the corporate health activists, that's a great way to put it. I actually never kind of put it that way, but that is a driving force, and obviously consumers. Impatient consumers, demanding consumers. So I want to bring Pat into the conversation because you have been Chief Medical Officer for some time, and you're also at Walgreens and creating that their healthcare experience. What? I'm sorry.
Yeah.
He was at Walgreens.
No, he
Until 3
was.
years ago.
That's what I said.
Yes.
He was at Walgreens, but he built that out
Yes.
basically over 5 years. And so, why did Walgreens get in? What are the circumstances besides the consumer-driven economic model, outdated? What were you seeing?
Sure. I'll talk about our employee health, which was actually the most exciting work I did there. But, why CVS and Walgreens getting into healthcare? You read it all the time. The fundamental business model they have is challenged. Front of the store, Amazon, I'd say it's also Dollar General. We're not selling as much. So quarter after quarter, our margins on the front of the store goes down 2 to 3%. And then what's getting squeezed is the pharmacy reimbursement. So your profit per script has been getting challenged. And so all of a sudden you have, like Walgreens, 9,600 stores, and you have real estate, square footage that's not paying. And on top of that, you have some of the best access points, bricks and mortar, in the country. Great parking across all socioeconomic areas. And we have huge digital assets, too, to connect those in. Our app was downloaded 60 million times. 3 million times per day someone's on our app or website. 8 million times per day folks are walking in and out of the store. Average diabetic comes in our store 40 to 60 times per year. When I was a primary care physician, I only see a diabetic patient 3 to 4 times per year. So it makes sense. Our business is being challenged. Bring healthcare in. CVS is doing the same thing. They're doing it in partnership with payer, which makes sense because they can enroll patients into Aetna, into that insurance product. Good ROI. For us, it's really about bringing folks in, convenient locations, and increasing pharmacy volume. So it's a good model, but we really didn't have any choice. I don't think CVS had any choice either because you have to pivot in the face of challenges. So that's why we did it at Walgreens. It's primary care, retail clinics, LabCorp services, really anything in the ecosystem we're going to bring in our stores. In terms of the employee health, which I think is really the most exciting thing that I was involved with at Walgreens, we had over 300,000 employees. We spent $1 billion per year for healthcare costs. And so about a year and a half ago, the gentleman who ran the benefits said, hey, you know much about population health? Yep, that's what I've done my whole career. I'm a primary care physician. I understand that space. Help me out. And so what we've done is we've reduced costs. We've not only flattened the cost curve for our employees at Walgreens, but we reduced it such that we've reduced the premium cost for our own team members. That's pretty amazing when you think about it, because everyone's premiums going up, ours went down. And we did that through really care navigation, pretty much what Solv has done, right? So at Walgreens, you have a card, health insurance card. You're either with Blue Cross or United. You call a 1-800 number. Guess what? If you want an MRI, you need an MRI, call that number. We're going to tell you the highest quality, lowest cost place to get that MRI. In Chicago, it'll cost you $600 at one place. It'll cost you $3,000 at our really nice health system, which charges you $3,000 for an MRI and they also add on a facility fee. And most of our employees and team members have high deductible health plans. Do not forget that. High deductible health plans is a fundamental change in your insurance. 82%, study came out recently, 82% of employees that have high deductible health plans never reach their deductible. So think of that. They have catastrophic insurance. So all of a sudden, our team members are thinking about, what am I paying out of pocket? What am I getting in return? And I think I'll go for that $600 MRI, because at Walgreens, not only you got the less out of pocket, but we also gave you a cash incentive to go to the cheaper place. And so we brought in some innovation around chronic disease, musculoskeletal, but the biggest driver of reducing our costs was care direction. So I think it's a fundamental change in how healthcare is being delivered today. Employers, as you know, most of the folks on this panel are aware, are really super uber focused on employee healthcare costs. And we are at Walgreens and CVS also providing access points to care with price transparency. So I think it's really two things that are coming together.
That's fantastic. So you also tackle the emergency room usage by steering care to the right place.
Right. Yeah.
Well, that's why Heather did this.
Yes.
So Archana, and I think, if we could have a national system like what you did at Walgreens, that would be great. So people can actually know where they need to go. So my 16-year-old just had to go to the emergency room a few days ago because it was 10 o'clock at night. So, but he only had 5 stitches. So we didn't really know where to go. We called Kaiser, like, oh, you have to go to the emergency room. There were no urgent cares that were open that late. But it would have been nice to have some sort of place to say, where do we go that it's not going to be so expensive? And so Solv is kind of trying to aggregate or be that service to direct people, right, to all of these different sources. So, I hope you can build that up. But that the other thing is that I think some of these access points need to be open 24/7. Here we are talking about access, and everybody shuts down at 5 o'clock, which is great. You have to go to, you have to be with your kids and all of that. But there's a lot of time, and I know urgent care is open till 8 and 9, but from a marketing standpoint, Karoline, since you're really into the marketing, everybody goes to the emergency room because they know it's accessible and they know it's available. So how can we do it where Solv, you're aggregating all of those, Heal, you should be 24/7. How do we get that education out that these access points are available?
Yeah, and it's almost like a 911 for healthcare in a way,
Yeah.
which is separate because it takes the load off of, we were just talking about that kind of a separate pathway. So it's not just the provider like Walgreens is paying for the 800 number, but it's a national resource that we could tap into. So how are you aggregating the Solv platform?
Yep.
Is that financially driven? Because of course, Trulia was in a way, so people trend higher or lower in that way. How are you aggregating? Who is paying you? What's kind of the business model that you're starting?
The business, actually, Tom, interestingly, in the very early days, I believe, I might be getting this story wrong, thought, let me build software to help modernize practices to deliver this consumer experience. Before it was, let's build facilities. And at the time, the market wasn't ready. And so we thought, the providers are not going to change. I'm just going to build a remarkable practice and then scale that from the ground up. So fast forward 10 years to where we are, and actually practices are ready. Right, and so the software that we sell on the supply side is everyone from innovative hospital systems powering their convenient care arm, whether that's their retail clinics, their telemed, and their urgent cares, all the way down to the mom and pop with 3 locations in Omaha. Right, and that's software that we sell for the practice. And so the way that we aggregate is 2 ways. One is, much like Trulia, we effectively have a directory, right, which is everything that is available with all of that information, and you'd be surprised how many are open until midnight, right? Because ultimately, convenient care operators are much more entrepreneurial. And they're SMBs. And so no one name owns more than 5% of the category. And so while my pediatrician stops answering the phone at 4:50 p.m., right, the pediatric urgent care trains across the country are open until midnight, right, because they recognize that it's after work and on the weekends when we have all of those issues. So our aggregation is both any clinics across the country is where we've started our focus. We've branched out and started powering telemedicine for providers. And then the paid providers on our platform are running our software internally, but we make all of that accessible to consumers. right? So ultimately, we want to help you make better decisions, right, as that front door of care, and then frankly, in partnership with providers and systems, help route you to the appropriate side of care. But putting that consumer lens, that consumer hat on first. I remember when I entered the category, people said to me, why is it so screwed up? And you already know this because you've all worked in the category for so long. But there's nothing complex about why it's screwed up. It's because none of the incentive alignment exists. And so it's super exciting. CVS Aetna, super exciting. What you did at Walgreens, you know, the stuff that's happening across these activist employers, I think is the best thing, I think, that's happened in the past decade in healthcare is all of these disruptors, frankly, forcing the bigger institutional organizations which provide wonderful academic care and great doctors, but it forces change, and that's exciting.
Heather, instead of just having a website, not everyone's going to have Solv Health, but from a marketing standpoint, can you have a phone number? Like, wouldn't it be awesome to be able to just, not 911, like 311? Or
Absolutely.
something?
May I address that? And
Yeah.
so when One Medical was founded and Tom Lee decided to build his own EMR, in those days, people were like, so? I mean, why are you doing that? I mean, it was cheaper probably than buying Epic or something else, right? So, but he did build it from the ground up, and initially, patients didn't pay that much attention. Now that has changed dramatically. So here we are in 2019, 60% of our patients engage with the app once a month. And our experience is for your middle of the night challenge is you just pick up our app and you push one button and you have a video visit. And the video visit is with a provider who can see your record. So if you've already gone to the doctor or your medicine isn't working or they can look at your history and help you figure out what to do. In the case of sutures, it might even be that we would ask, you might be able to wait till the morning, you know, because, so we basically prevent, this is very much like what Crossover does too, I think we prevent most emergency room visits. There's just really no reason to go. I'm sorry, most urgent care visits, about half the emergency room. So there are legitimate reasons that people, you've broken, compound fracture, you gotta go to the emergency room, right?
It's 70%. They didn't need to be in the emergency room.
Oh, yeah. That's very true. So, and has anyone been to the emergency room lately? I mean, nothing against our lovely hospital partners, but I mean, it is, did anybody have fun? I mean, it's not, it's very, and one of the things I must say, working at Stanford, I was so impressed with how complicated managing a trauma center. It's impossible. So the fact if you walk in and you have a broken leg and you can get in and out of there in 6 hours, you are lucky. Because they're doing, heroic stuff on other people. So I think this is part of the issue is and maybe for today about whether you need a clinic or you need a digital app. And if you can have access to a video visit in the middle of the night where you can show the doctor what it is, then do you really need to physically go? In a lot of cases, you don't.
Hey, Justin, now you have a great service where the doctor goes to your house. So would it have been more affordable to actually go see a patient and stitch them up there? I mean, it seems like it would be more affordable than the emergency room, but would it even be worthwhile for your business?
We do that actually. So in our house calls, we actually take a medical kit that includes all kinds of supplies, including suture materials, EKG, basically almost anything you would see in a typical doctor's office. And to your earlier question of like what has really enabled this growth and being more consumer driven, I think a lot of this is technology, right? I think that whether it's like the AI tools that are used to steer patients the right way, or the in-app messaging or telemedicine that we do, specifically for house calls, if you think about it, in the early 20th century, like in the 1930s, almost 80% of doctor encounters were in the house. And I have no idea how that was possible, frankly, because technology has really grown tremendously where, the way we do our routing, we basically have an API with Google Maps and it's all automated routing, meaning you put in your symptoms, you put in where you are, and our back end routes the doctor and the medical assistant to your house, right? So I don't know how they would have done this without maps, right? Without, do they pull out the Thompson guide and go to page 300 ACE? It's impossible. And then same idea with the EMR. I think it helps quite a bit to, for us for our doctors to be able to provide that same telemedicine experience, seeing the EMR records. And we were also benefiting from the miniaturization of technology, right? Where we can take things to the patient's home that are tiny. And that might be an EKG machine that's literally the size of this glass, right? Or, we do retinal screening for HEDIS measures. We look at the back of the patient's eyes who have diabetes. So there's so many examples of technology that are really enabling the growth and the innovation here. And then to your question about like costs, certainly it is certainly cost effective because these ER visits are costly, right? Sometimes over $2,000. You add in an ambulance ride, even more, right? And so you can deploy a doctor and a medical assistant cost effectively, go to the patient's home, divert an ER visit, and deliver high quality care. So that's what we're all about.
No, it's actually, my son was hit by a car. He was fine, but that was $45,000. He was in the hospital for 3 hours. He was demanding to leave. They're like, no, stay. He's like, I'm fine. And $45,000 bill later.
I don't know why we are leaning towards cost, because we will talk about
I know.
But it
Sorry.
almost seems like cost is woven into care. And I think care experience and perception of care has cost as probably one of the biggest factors that we look at. Did I receive good care or not? And was it at good cost or not? So almost like each one of you seem to have defined care in your own flavor and way with your own tools. But I had a little conversation with Karoline out there. You didn't have wine at that time.
Depends on the
It depends on the
conversation.
So she was saying, I don't believe in the future of clinics. And I'm like, are you automating the physician? Or are you replacing the physician with your digital app? Or is it? What are you doing out there?
I did. And I said the same thing to Bambi when she said, what's your perspective on this panel? And I said, well, I just don't believe in the future of clinics, damn it. Because I don't. I think we're all saying the same thing, which is the theme is digital first to account for a highly mobile, highly healthy in general, potentially rural patient population that is just a new way of life. But I think just to back up on one point, I would not define care as cost. I think cost is a reality, but I would define care as trust. At the core of all these models which work, there is trust driven by time with the provider, trust driven by clinical excellence, trust driven by immediate access. And so all of us are saying that same thing, but back to the, damn it, not clinic points, it's really about a digital first, team-based experience. I believe that the models, somebody up here said, I think Jenni, or maybe someone else said, Teladoc and MD Live are not integrated. And that is true. Those are bolt-on solutions. We at Crossover deeply believe in a digital first experience with a dedicated, integrated team that will always see you, whether it's 2 a.m., 2 p.m., and have access to your clinical records, right? Part of the challenge is infrastructural. If you are constantly repeating your story and the provider has a very limited amount of time, it is not going to drive trust, and therefore it is not going to drive care. And I'll let the others pipe in. I think Walgreens had a similar perspective.
Yeah, when I speak about healthcare, I use examples of my 3 millennials, and I don't tell them the stories that I tell others, but I got a recent one with my daughter. She was had some really funky neuropathy symptoms and overwhelming fatigue. This was about 3 months ago, and went to her primary care physician, who had literally 7 minutes. She counted it because she's looking at her EMR, right? And so my daughter is, 30 years old, senior director of IT at DaVita, very bright. And so primary care doc said, it's nothing, you're anxious, you just had a baby, here's some Klonopin, which is like the worst medication you can give someone that's highly addicted benzodiazepine. So my daughter called me like they always do. They either text me or call me and said, Dad, I don't know what to do. And I said, what are your symptoms? And she'd actually went on Google. Like 35% of folks Google when they have symptoms. She said, I think I might have hypothyroid, and Hashimoto's hypothyroid is actually associated with peripheral neuropathy. And I thought, wow. you know, I've been out of practice for a couple of years, but I didn't even pick up on that. And she went through her symptom list. She read some articles in the New York Times about someone who had very similar things. She called her primary care physician and demanded those labs. Sure enough, her thyroid antibodies, her TSH is way up, her Hashimoto antibody markers are way up, and then she arranged the visit for her endocrinology appointment. Did we need a primary care physician in that? No. My daughter texted me and said, Dad, healthcare is going to AI-backed symptom checkers and to get you to the right place, to get you the right lab tests at the right time. And all my primary care physician did was actually hinder my progress to getting a diagnosis and getting better. Pretty interesting. And I can tell you that if you actually look at studies, a lot of folks don't even want to see a physician face-to-face. Even on telehealth platform, many are very comfortable in not having a physician face interaction. That's basically what HIMSS is based on, asynchronous communication. As long as they get the information and get the right direction, they're fine with that. So I do think we have to actually ask, as a primary care physician, this hurts me, is what is the future of clinics? What is the future of primary care? I think it's changing dramatically.
And I thought I had to fight Karoline for this. I mean, I'm a primary care physician, and of course, that story does not justify the rest of the primary care physicians out there. And of course, you are also representing one of the primary care. But I do believe that the time becomes a huge factor. I do believe that the providers' burnout becomes a huge factor in being able to dwell into symptoms, because Mr. Google can you know, if spent time on it and accurately, can almost close to predict 4 or 5 diagnoses. But a primary care physician who is well-trained, has enough time and resources, can possibly not only accurately diagnose and provide a good treatment, not Klonopin. That is a disaster in making. And definitely save cost, which we'll talk in the second half of this course. Yes.
Well, I think,
Did I represent you okay?
Yeah.
Okay.
I think, okay, go ahead.
No, I mean, I was just going to add, I think, you know, since we're in the virtual first space for primary care and doing panel management, we have found that we've been able to move care, 90% of our care, to virtual. Mm-hmm. And when we say virtual, I feel like a lot of people talk about video visits, but actually what we find, patients are preferring just having a telephone conversation, mm-hmm. right? Yeah. It is just, once that relationship and trust has been established, then they want sort of the most expedient way to transmit information. And so,
do they need to speak to a primary care physician, or is it a nurse practitioner?
Yeah,
who do
right. We haven't talked any about this, but the care model, I think the care model also is very important. I mean, there's been a lot of work in the patient-centered medical home, et cetera. But one of the things that we do, and specifically in supporting patients who have chronic disease, is have a health coach that's integrated with our practice. So a diabetic patient might have 1 touch point with me in a year, but they will have 20 touch points with a dietitian health coach. And again, so I think that is part of sort of rethinking the way, so that's not a physician-centric experience that patients are having.
I think you and crossover the same way, but I think with One Medical and Heal, it's more physician-centric. You're about, I mean, you have a team, but I think you're about, you want your doctor to be well versed in all of those things, and to spend 30 minutes, 40 minutes with the patient and do all of those things. So you have the team-based approach and doctor approach.
Yeah, I mean, I would disagree a little bit with Karoline. I think in terms of, I don't think the clinic is dead, and I don't think the doctor is dead at all. There's no evidence. One Medical is growing incredibly fast with physical offices and digitally. And what's that all about? You have to have good offices and good doctors and good technology to grow, right? Because there is a tremendous demand for people to physically come in, spend 30 minutes with someone who actually cares about you, knows about you, will listen to you. And in our clinics, we draw your blood. And this is one of our biggest patient satisfiers, is we draw your blood and we send it to LabQuest,
yes.
Whoever your contract, you know, it's not a money maker for us, but it's a huge patient satisfier. So it's physical, right? People want to check their cholesterol. So I think we have to be a little bit careful. I don't want to throw the baby out with the bathwater. I think, you know, sucky clinics and not very nice doctors are dead. But good ones are probably going to be around. And you need also the clinic to be physically located in a place that's convenient to people. That's something that's also very different, and we do distribute our clinics in high-density areas to make it easier to get there.
And I would say digital first, clinic follows as optional.
Yeah. So I think well, yes, of course.
So I may offer one analogy. When 10 years ago at
Is this the
Trulia,
doctor is dead team on that side?
No, no, no.
and then the doctor
when I was at
is-
Trulia, I sat on a number of panels where they said, is the real estate agent dead? Are they dead? Are real estate brokers going away? And there were some people who were like, absolute dead technology. And our response then is the same as mine now, which is the reality of care is consumers have disaggregated it, and there will be different flavors for different needs. When my son Cyrus had a rash during the day, he's largely healthy, to talk to some rando on telemed through DOD was totally fine. Right? Because then I knew I didn't have to cancel my day. I can send my son Cyrus to school. However, if we are when I have my annual, I might want to talk to someone. It will be driven by preference. It will be driven by access and need. But there's not one, in my opinion, digital first, clinic first, must have doctor, don't have doctor. There's a theory of the way it should be, and then there's the actuality of how consumers are managing their care today. And my view is that will be much more disaggregated and different flavors depending on your use case.
And I think that's where we are all going, is like whatever works for the member, and member-centric or human-centric, like Amira talks about. So I think it is the door needs to be there, whether the door takes you to the app or the door takes you to the primary care physician, either one would be fine. I have a question for Mana. Because you have been quiet for a very long time. And I'm curious to know, because I did see Dignity Health and UCSF and so much more collaboration that's happening up in the North Bay. And I'm curious to know how you are working in the specialty field, because we are all talking primary care at this point. How are you extending the specialists and centers of excellence?
So, good question, and thank you. And I was listening to all this, and there are a couple of comments I want to make to the discussions that were going on. I think we're we're all very technology savvy, and smartphone has done that for us. We've become very technology savvy. The thing that we all have to keep in mind as we're already thinking about all these things is also your segmentation of your population. So, the younger generation really wants to go all digital, and when I want to really have my physical, I'll go to the primary care, and then I want to really go to the clinic. But don't forget the number of older population that we are having and how long those people are living, and how do you provide access to them? How do you manage their disease? And then things like Hilu probably come into it really as a good solution, where you can provide the right care at the right time in the shortest possible, and hopefully it's cost effective. So I think that to me is really, we have to really think of that. I think we are in Silicon Valley, and I myself, I love technologies, and when I try to really think about it in the context of Dignity Health, it takes a monumental thing to kind of really shift. So our strategy is partner in terms of really how do you provide better access, how do you provide cheaper access, but we have to really look in terms of the segmentation of the population. We really try very hard to send people that are coming to the ERs to go to urgent cares. And you will find there's a demographic of patients, no matter what you do, they're going to turn up in the ER, right? You really don't need to see someone in ER. And we're happy to not have that revenue, but changing that patient's behavior is very, very hard. So I want you to keep that in mind as you really think about, your population, the younger population, the 40s to the, 60s, and then the older population. And I don't think we should forget that in the context. So, from a specialist point of care and center of excellence is, it's almost the same strategy, either whether you take neuroscience or whether you take oncology. It's really how do you really get economies of scale and efficiency from a technical, clinical expertise to making sure that is not costing you so much. So telemedicine is a really important component. Being able to really share information through the technology, that you can get information from the primary care to the specialist seamlessly as possible. And then how do you access the academic medical care specialist? How do you build that relationship? But it's all really based on technology-driven, time to results, and being able to make sure that when you send, the patient gets the care in the fastest time. They don't have to come to a primary care, then to a specialist, and then to a super specialist to really see. So we're trying to really bridge that gap through being able to use telemedicine and then technology as a driver. And then we're not forgetting access points, and we're not forgetting how do you really also partner with some of these younger digital savvy providers to really make sure that, you know, we think about population health and not just only when patients are very sick they come to us.
What I was curious to understand is that specific solution. So telemedicine, how we see is patient-oriented or patient-directed solution. What I saw at Dignity and UCSF relationship is a telemedicine MD to MD. And that's kind of saving that specialist visit for the patient real time and being able to make a consultation and make a decision, which was very powerful as a provider or primary care provider to me, and also for the patients too, directly.
Tumor boards are a good example of that. You know, neuroimaging is very important. So you don't have, you know, you have sort of the best of the academic center. How do you really take that imaging, send it over, get a consult, and it's done, right? So it really saves a lot of time and money for the patient.
Excellent.
So,
time's up?
yeah, we have time's up, but I do want to say that I think that the great thing about the way we formatted it is that we are going to have all of these guys back in 20 minutes. And so we didn't have much time for questions from here. And I know this gentleman over there, is it like burning inside? Do you have to ask that question? Okay. But I think that
burning, come out with it.
But I think that what we'll do is we'll open it up with questions the next time when we come back. So we'll do that. But
before we leave, we have
Yes.
talked so much about technology. And when I joined HP, I had no idea HP is a major play in healthcare. And so I thought, you know, this is a great forum because we are reinventing our future of clinics. And I wanted to kind of have the HP expert in Healthcare Edition to come and talk about how is HP enabling our providers to really reinvent the future of clinics.
Sure, I'll do that. Thank you. Thank you, Archana. Can you hear me? Yeah. Hi, everyone. So I'm Raja Bhaduri, and I'm part of HP, and I manage the care delivery portfolio in HP. How many of you know that HP has healthcare customers and is in healthcare? Okay, not everyone in the room, which is surprising, but we really are a major player in healthcare, and we serve healthcare customers. Thank you. We serve healthcare customers across the world. And when you look at our customers, we have the very large academic medical centers, including Stanford across the road, Kaiser Permanente, we have Crossover Health, and so on and so forth, right? So we have, in the past, just sold our enterprise-grade products to healthcare customers, right? So people bought our computers, our displays, because of their quality and reliability and security and manageability and so on and so forth. But then, we have, a couple of years ago, we decided to make a very big investment in healthcare. And we have a healthcare advisory council. Dr. Dubey is part of that council, so we are very glad to have her. We have other members from Mayo Clinic, Sloan Kettering, Kaiser Permanente, et cetera, on that advisory council. And we meet with them regularly to really understand what are the challenges that they are facing in healthcare, some of the disruptive megatrends that were touched on as well. Plus, we are, members of HIMSS and CHIME and so on and so forth. So what we've started doing is more and more developing these healthcare edition products, which are based on the insights and the feedback we get from our customers. And these are really designed to be what we simply describe as safer, smarter, and secured for healthcare. And I'll touch on these a little bit. These are some themes that kept coming up again and again as we talk to our customers. The first one, with the safer aspect, didn't really come up in this panel discussion much, but when you think about it, with the surge in electronic medical records and so on, you think about these computers and displays. They are right there by the patient bedside, right? And there are numerous studies which have been done to show that these devices and the smartphones that people are carrying around in hospitals are really disgusting. I mean, they are filthy, right? And when you think about hospital acquired infections or healthcare associated infections, HAIs, right? The numbers are staggering. Any guesses how many people die in the US of healthcare associated infections? These are typically infections that pick up at a hospital. Any guesses? Don't be shy. You're spot on. Who said that? Wow, someone is an expert here. You're right. It's 100,000 people, and over 1 million people, almost 1.7 million according to CDC, acquire these infections while they're at the hospital. Now, traditionally, the sources of these infections were, it's catheter-associated UTIs or surgical site infections. But now, the infection preventionist community is looking more and more at technology devices, at environmental surfaces, bed rails, sinks, doorknobs, etc., and saying, wow, there are pathogens lurking there, and what can be done? And so we've taken a really, really hard look at this issue. Now, one of the things we looked at was early on when we started developing these products were antimicrobial coatings, right? Some technology companies go this route, antimicrobial coatings. But the problem with antimicrobial coatings is, first of all, there's a lot of research that shows that they're simply not very effective. Worse, they sort of lull people into a sense of complacency. People think, oh, this has an antimicrobial coating, so I don't really need to clean and disinfect, But the problem is you really do need to clean and disinfect the stuff. And what you're cleaning these IT equipment with are very harsh, very caustic bleach, quaternary ammonium compounds, accelerated hydrogen peroxide compounds. And so what we decided to do was really design our healthcare edition products. So there's a separate class of purpose-built products, healthcare edition, which are designed to be cleaned and disinfected with germicidal wipes every shift, every day. Actually, we've tested them to 10,000 wipes a day during the life cycle, 10,000 wipes based on feedback from Dr. Dubey and others, right? So really, really important. And what this picture is showing you is on the left, a regular keyboard, and what happens to it after it's been wiped a few times with PDI SaniCloth, which is a quaternary ammonium compound, right? So these, again, you need to clean these things with germicidal wipes to kill the pathogens. But these IT products were never really designed to be wiped down with these things. And on the right, you see this the keyboard on a healthcare edition product. So again, the safer piece, really important. We've also tested to higher emission standards. The other thing, and this came up a little bit, it's just doctors are just stretched. They are getting burned out. They have to see so many patients over the course of the day. So one of the things we heard about, including from Dr. Dubey in her sort of previous role earlier, was just how many times they have to log in and log out. It's absolutely ridiculous, right? As they move from room to room, floor to floor. So we worked very hard with Imprivata and HealthCast and other single sign-on vendors to really integrate the RFID features inside the computers. So rather than having an external RFID badge readers, they simply tap their badge on the computer. They know exactly where it is. They don't have to go hunting for external badge readers. Obviously, it's part of the computer. It's integrated, so it's fully sanitizable. And so with a simple tap, they're authenticated. It doesn't disrupt their sort of cognitive flow. They don't have to think about, what's the password, my kid's name, my dog's name, was there a number associated with it? They just tap and go, and that's it, right? So we've done these things, again, through partnerships with Imprivata and HealthCast and others. And then another thing that we've done is integrated tracking support. What our customers told us, again, just boggles the mind, is they typically purchase 10 to 20% more equipment than they need because the staff can never find it. They cannot find the medical carts when they need them and all that stuff, right? So talk about bending the cost curve. It's things like this, right, which technology, as a technology company, we can absolutely address. So our newest healthcare edition products have this optional tracking support. It's an RFID module built in, and it helps them track the device across the care setting. And this is not just for inventory management. What our customers have told us is now when our healthcare edition all-in-one is on a medical cart, they'll know exactly where it is. And so if a cart is moving for some reason, let's say from an infectious diseases unit into the pediatrics ward, then they will know of it, and through solutions through Stanley Healthcare and so on, they can do something about it, right? So really, really important stuff. Again, not rocket science, but we've managed to build all of these things in. And then security, absolutely important. We secure devices at the BIOS level because healthcare obviously is the number one target when it comes to the bad guys, the hackers, right? When you look at the number of breaches year on year, it just keeps increasing. When you look at the OCR's, the Office of Civil Rights, part of HHS, when you look at their wall of shame, organizations that have been hacked, that have had healthcare breaches, it's absolutely staggering, and that number again keeps growing. So we've done a lot of things in terms of security. Now, Archana mentioned at the outset that we have a couple of healthcare edition devices. Those devices there are very sorry, unhappy looking devices, and I have to apologize for that. But those are the pre-production units that I was able to scramble up for this meeting. The real units are all with customers, thankfully, which is exactly where they should be, including demo units of products that we launched just a couple of weeks ago. But the reason I still thought it might be useful to bring those is because both of those devices have a feature called something similar to the HP SureView, which is a privacy panel built into the devices. And you can toggle on the laptop, you can see you can toggle the privacy panel on and off. Very nice, because a lot of our healthcare partners said, you know what, our clinicians hate having the privacy, right?
Yes,
it's
so
terrible.
It is, I asked for it, by the way.
Yeah, you were one.
So it's one button and it becomes private. So you could be an airport and other things. And with one button, it becomes collaborative. Because in my day-to-day work, I want to share the screen, and it's super easy. And then I don't want to share the screen because I'm doing patient work. So it's very practical, but it's really good. And then its sanitizable part becomes real because I don't have to stick something on the top of it. So,
yeah, you don't have to do that, and you don't have to trim to size and all
Yes.
that crap. And again, hospitals, they're becoming more and more welcoming, right? I mean, so even think about the reception desk, right? And you don't want those filters sticking there, it's scratched up, whatever. People are throwing them away, and then every time JCO comes around, everyone's scrambling, trying to stick those privacy filters on there. We just said, look, we can do something about that. So the visual privacy is important. So again, we have, as part of our Healthcare Edition portfolio, an all-in-one. We have, which has several interesting things, including the privacy screen that we mentioned, telemedicine ready. This came up a lot in the conversation.
And a pop-up screen.
Yeah.
Pop-up
camera, yeah,
which is
exactly.
important.
You see that at the top, right?
Yes.
So this is something else our clinicians wanted, so that everyone knew exactly when the webcam was on and when it was off. You simply pop it up, pop it down. And we partnered with a company called Vidyo, V-I-D-Y-O. And Vidyo actually is a leader in the telemedicine platform, so deeply integrated into EMRs. In fact, I think Kaiser Permanente is an investor in them, so we work very closely with them to make sure we just work very, very well with Vidyo. So anyway, I just wanted to quickly mention, and thank you, Dr. Dubey, for your time. We have a Healthcare Edition notebook as well. We have Healthcare Edition clinical reviews, displays. And just very quickly on the opioid crisis, we have a fingerprint reader, a FIPS 201 compliant fingerprint reader, which is an optional feature on the notebook, because HP has also taken a stand on what we can do to fight the opioid crisis, and clinical prescription pads and all that. I mean, it's just open to fraud and abuse, and so we've got these fingerprint readers installed in them as well. So again, it's about, safer, smarter, secured for healthcare. So we have these Healthcare Edition products, and it's terrific, being able to partner with folks like you to keep pushing that and really be an ally in finding ways in which to make these devices safer to use in clinical care settings, right? And also look at ways to optimize workflows so that clinicians are spending less time with the technology and more time with their patients. So thank you, everyone.
Thank you. So we go for the break? Yeah. Yes. 7:20. Yes. Thank you.